We are broadcasting, recording, and ready to start.
Great, thank you, Jenny. Good morning, good afternoon, everyone, and welcome to today's webinar, Public Health Emergencies. It's not just plagues and pestilence. Jenny mentioned the Q&A option. I'll be moderating questions at the end of the presentation, and as Jenny mentioned, to ask a question, please click on the Q&A icon at the bottom of your screen, type in your question there, and I'll moderate them at the end of the presentation. It's my pleasure to introduce our speaker today, Dr. David Bulter-Jones. He was the Chief Public Health Officer of Canada and the Deputy Minister of the Public Health Agency of Canada from 2004 to 2014. Dr. Jones, I'll turn it over to you.
Okay, thank you very much. Really is a pleasure to be with you this morning or this afternoon, depending on where you are in the country, and hope that all is well with you. And it's a very crazy time. Everybody's very busy. When I was asked, this is, as you probably know, is linked to a special edition of Health Management Forum looking at pandemics, and it's quite kind of ironic that I was asked if I would be guest editor for this about a year ago or so, and with no idea that we'd actually be in the midst of a new pandemic of coronavirus. So part of the presentation will be actually looking at a bit at the past, particularly as it relates to influenza pandemics and SARS, etc., but also talking about what we're in the midst of, and I'll leave hopefully most of the time for an opportunity for questions, etc. So anyways, point of this slide really is about everything's connected, and if we try to break things down, look things specific, the reality is that our major epidemics, outbreaks, etc., actually come from domestic animals or others in the wild, etc., and having that close contact, and literally. When the Europeans first arrived in the Americas, they brought these Eurasian diseases like smallpox and measles and others that had been circulating in Europe and Asia for a number of for a long time, and so had already selected some relative resistance. And so within 200 years of Columbus's arrival, some 90% of the population in the Americas was wiped out by these range of diseases, and it's a tremendous impact, and something that we're not done with them yet. So the public health threats generally, I mean, it's a mix of, as we're seeing, and people now talk about the Anthropocene and just how the impact of humans and populations, etc. And you'll have a mix of the kind of the threats that we face. It's all interrelated, and as habitats destroyed, as you have closer association between humans and both domestic and non-domestic bushmeats, etc. And we have, I talk now about One Health, which is a concept which really recognizes the interactions between human, animal, the environment, and the economy. And it is something that really requires thinking across sectors, across disciplines, both in anticipation, but also in response to the various things that we face. And we tend to classify public health emergencies into radionuclear, toxic substances, and or contamination, such as we saw with melamine in baby formula or pet food, to artificially raise the appearance, the level of protein, or drugs like the current opioid crisis that we're continuing to try to address, the infectious ones, which is going to be most of the conversation today, as well as the health effects that come from natural or human disasters, whether it's war or natural disasters, or some of the things that we do to our environment, etc. So public health emergency planning really is a component of all hazards planning. Thing is, it's not usually a single event, and it can go on for weeks or months. And depending on how we initially respond, we may actually make it worse or make it last, make it longer than it need be. And it also, because it can affect those who are actually responding to it, or in planning for, pandemics, et cetera. We have to think about truckers and, food supply chains and a whole range of things, not just supplies for hospitals, et cetera. And then we have the challenge of the fear of contagion, and the reality that sometimes it's us physicians or other health workers who actually, are the ones that not intentionally, but because for some of these we can be infectious before we're actually have any symptoms, let alone mild symptoms. We can actually bring it into nursing homes, hospitals, etc. And so it really is a challenge thinking that, well, we have to think through all these things. And the economic impacts over the last couple of decades have just really increased tremendously. We don't have numbers for the COVID-19 yet, but I'm sure it'll be up closer to the H1N1 pandemic of 2000 and 2009. So this is a quote I like, and you probably heard this from President Eisenhower, and it really is about the planning. It's less about the plan that you produce, but the process and planning, making the connections so that when you're in a crisis, you know who you're dealing with. It's not cold calls to the partners that you need, et cetera, as well as the ability to plan for the things that we could imagine, and then that we can the reality is that there'll always be surprises, and then our energies can go to addressing those surprises as opposed to trying to just figure out the basics. For pandemics of influenza, which kind of defined a lot of the last century, and it was a long time between the 60s and the pandemic in 2009, and 1918 is the sort of the hallmark in the modern era and worldwide, in the impacts worldwide. But the reality is 99.5% of Canadians survived the Great Pandemic of 1918. And while the stories of that acute pneumonia, viral pneumonia in the young healthy farmer one day and dead a few days later is really dramatic and true, but some 95% of the deaths actually were not that primary viral pneumonia, but secondary bacterial pneumonias, and just a big part of the reason why the subsequent influenza pandemics in the 50s and 60s much lower mortality, because by this time we had both antibiotics, better healthcare, better general health, etc. And the thing is with the pandemics, they tend to, because it's a novel virus that we haven't been exposed to, except that just like in 1918, 2009, those of us on the older end of the age many would have been exposed to an earlier circulating similar virus that then provided some measure of protection. But young adults and children were particularly vulnerable because they had no prior exposure. So in 2009, one of the things which is actually quite I think Canada deserves a lot of credit, because we actually did stop the pandemic before Christmas, in combination of the planning, preparation, the different public health capacities across the country, and emergency planning in healthcare and other sectors, having a stockpile of antivirals, having quick access relatively to a vaccine sufficient for the whole population, and all the individual measures, whether it's hand sanitizers, washing hands, avoiding people when you're sick, etc. Was really, anyways, it was an impressive feat, and few, if any, other countries can actually say that, and many still were filling their ICUs the following flu season. Some of the lessons from 2009 really are about the importance of flexibility and scalability in the pandemic plan, and that the usual processes that we would have in between crises really don't work, because you have to make decisions quickly on the fly, and these have huge impacts. having clear governance structures, making sure that we're able to share the information across jurisdictions as well as with the public. And one of the things that I insisted on in 2009 was that provincial and territorial public health officials, chief medical officers, premiers, ministers, etc., would know what I knew shortly after I knew it, to make sure that we're all working from the same basis of information. And while nobody, would be told what to say or anything, it was striking just, how when, smart people, given the same information, can generally come to a reasonable consensus. And then came Ebola. And it really seemed like we'd forgotten many of the lessons of SARS. There wasn't a measured response. Initially, it was a very weak response in West Africa. And then later, this overreaction. And so, developed countries would have people that normally have important public health and other work to do, sitting in airports just in case somebody showed up, etc., and not really thinking through what would be necessary or effective in terms of advising people or what kind of restrictions you need, etc. And so it really also diverted resources from other programs. It's very expensive, and fear seemed to trump function in many ways. And Ebola, much like SARS-1, should be manageable. It's being a zoonotic, it's occasionally affects humans. You actually have to have contact with either ingestion or mucous membrane, etc. It certainly was a challenge, and many of you would have lived through that. But really only infectious when you're actually very sick. So you can identify who's sick. You can do isolation, personal protection, etc. And generally the transmission is very low unless you're actually dealing with dealing with them, which is why it was largely hospital. SARS-1 was largely a hospital outbreak, and there are a number of things in West Africa that really made it challenging in terms of burial practices and other things. Clearly the using hand hygiene, the use of gloves, masks, goggles, etc., infection prevention and control practices, and the same, in many ways, why we talk about universal precautions, because there's just so many things that we don't know what we're facing, and universal precautions are effective at any time, especially in one of these situations. And West Africa is challenged as the development moved away, very little in the way of a good primary health services system, poor education, years of civil war and poverty, lack of trust in government, traditional burial practice, as I that involve a lot of contact with the body, and a slow response initially when you can get ahead of the game. So one of the observations is, public health is local, but it can be 1,000 localities at the same time. And it always is in the context of that. And that's why you need capacities provincially, nationally, internationally, to be value added to that. There always is, Theresa Tam likes to quip that once you've seen one pandemic, you've seen one pandemic. And the reality is there's always differences, that you have to be flexible and prepared for that. And having the plans in place allow us to, as I mentioned before, to focus on the surprises. And it really is there's nobody owns this. It really does require all of us at different levels to be engaged. And this is Rachel Nelson, and you would recognize Vimy Ridge. And the point of that is, how, for example, the British Navy was pretty good, but they became unstoppable when, prior to Nelson's era, the admirals would, sit down with the captains, lay out a battle plan, you follow in line, etc. But in his time, basically, they talked about the objectives and what the plan was, but allowed captains to adjust in the midst of battle, and then they became unstoppable. And Vimy Ridge. General Curry, again, through all levels, not just officers, but enlisted soldiers, etc., and would understand what the objectives were, and would have the ability and were supported in adjusting. And so when nobody else did it, the Canadians did. And so it's important about delegation, communication, understanding objectives, and allowing people to make decisions as need be in the field and to learn from those decisions. As I was saying, it's all connected, and you never know what it's going to be, and there's always surprises. It's like one outbreak we saw of salmonella in people. It turns out it was the pig's ears that the dried pig's ears that they would give their dogs as a chew toy. You just never know where it's going to come from. There's always the complexities of all these linkages. We have a changing climate, which means that some of these diseases are moving into areas, whether it's West Nile or chikungunya or others, that moving into areas that were not, particularly as you see, mosquitoes and others shift or be in the Americas. One of the things that we don't always talk about, but is really important, is that a lot of particularly natural disasters tend to affect areas that, for example, low-lying with floods, but also tend to be populated by people who are poorer, fewer resources, etc. Also the capacity to actually understand and assess health risks, the health systems in different countries, etc. And just how, collectively, if everybody's on the same side, it's makes things a lot easier to move in a positive direction. And now we have SARS-2 or COVID-19, whatever you want to refer to it as. And the reality is the virus itself is less dangerous than pandemic H1 was. However, we don't have available treatments for the vaccine. Unlike SARS-1, it can be infectious, not just when we're actually quite ill, but prior, for a day or two before having symptoms, and we're actually can be very infectious with minimal symptoms when we think it's just a cold or allergies, etc. And something else to note is that coronavirus, it does include strains that we consider as common colds. The highest risk groups we're seeing are really much as we would see in seasonal flu and unlike pandemic influenza. So it's interesting and challenging mix of influenza-like or SARS-like kinds of characteristics. And you would know, I mean, some of this will be familiar, obviously, to you, but we're just going through it quickly. So what we know is that you're actually infectious prior to having symptoms. And we're most infectious, as I mentioned early on, and underlying chronic conditions or lowered immunity that comes with either immune deficiencies or cancer treatment or other treatments, or as we age, our immune system does not respond as quickly, etc. We think prior infection will offer immunity because we've seen certainly the sera from recovered cases does reduce the mortality in other cases. It's social distancing and isolation definitely is slowing the spread. Leveling the curve has been the jargon. And face coverings that not in a medical setting, but face coverings generally, they likely reduce the risk to others. In other words, because we're not spewing droplets and that. And if we're keeping our hands away from our face, etc., we're not handling things that then other people handle, and then they touch their eyes or nose, or whatever. And it may be of some help, but limited help for where. Generally, I mean, the evidence that we have generally is from other, influenza, other diseases, etc. And because of, you're more likely to be adjusting the mask, touching your face, etc. And not everybody washes their hands before putting on the mask or taking it off, as well as sometimes we're not thinking, and we saw this in SARS. Sometimes, we don't even think about it. We don't even realize how much we touch our face, and we, slip a finger under the mask to scratch our nose or whatever. It's just often these are things are just not even conscious, and so it's and the risk is, and the concern is, if people think they're safer, then they're less careful about distancing and hand washing and other things. And so, but generally, what more and more encouraging facial covering. Whether it's a cloth mask or whatever, just, when you're out and you can't social distance to reduce the potential spread to others. And it may help for yourself, but that nobody should be under the illusion that that's a guarantee. Things we don't know, there's actually a much longer list than this, but we don't know how effective the antibodies are that are being produced. How long does the immunity last? Is there any protection for other strains as this virus evolves, or could we, get sick again? Which also is, so many commercial and other, development of antibody tests, but will it be specific to this virus, or would it confuse antibodies from having had a coronavirus, other coronavirus infection, cold, whatever? Are there long-term carriers who can continue to shed the virus? There may be. We're not really certain about that, and we don't have prior experience with this virus to guide us. What level of social distancing? What as things start to move up, what's going to be necessary moving forward as we live with this virus? Certainly, frequent washing of hands, use of hand sanitizers, keeping our hands away from our face, coughing or sneezing into tissue and disposing of it, and washing our hands or into our sleeve, etc. Those are all good things at any time in terms of reducing the risk of respiratory viruses and other things. And it's interesting, when during pandemics or outbreaks, we often see other nosocomial infections reduced, as well as food poisoning outbreaks, as people get more careful about hygiene and sanitation, etc. And when might we actually see a vaccine and more effective antiviral treatments? And that's the question. That's an open question. There's many very promising things out there, but we're not there yet. So this is actually, it's a very busy slide. This is from Worldometers, rather. And it's actually a very interesting website. They track a number of things, but you can actually go onto that website and you'll see, what, in this case with COVID, among the most affected countries. And as you can see here, the US is well ahead. Not a good thing, and it also is an opportunity to check some claims around. Of course, we do more testing than anybody else in the world, or we have fewer care, whatever it is. It's actually a bit of a sobering look. I just thought I'd share with you, having been involved with a range of crises. And when, there's lots of, you can do courses and stuff on risk communications or communicating crisis, but there's basically, I would just say there's 5 things to always keep in mind that to be shared. That's what we know, what we don't know, what we're doing to find out, what we're doing to address the issues, and equally important, and maybe even more important, is what can you do to protect yourself, your loved ones, and others. And that's where you see a lot of, certainly during COVID, a lot better communications compared to SARS-1. and from provincial medical officers, premiers, and ministers, and others, as well as federally. And always, these are the things that you can do too, because it's not just in COVID. These things, these kinds of measures are always important, and can in fact make a big difference. So, anyways, that's the end of my presentation. This is a quote I like from Samuel Clemens. Even when we're on the right track, if we're not moving, we'll get run over. So we have to keep moving, and we have to keep working on this. And so I will stop there, and we should have a good amount of time for some questions.
Terrific, thank you. Like you said, somewhat sobering, but your knowledge and experience is shining through. One question came in wondering about the details of the website. I think you said Worldometer.
Yes.
Yeah.
Yeah. I'll back up. I'll just leave that on, and so Worldometers.
Worldometer.
But if you do if you Google Worldometer and COVID-19 or COVID, it should come up in your search as well. But you can see in the bottom right hand corner is the web address for this particular part of the site that looks at COVID-19.
Perfect, thank you. Another question, can you speak to the large variations of incidents in Canada?
Yeah, partly it's population density. So larger cities, more opportunity for people to run into other people who might be infected. Partly where it started. And when it started early, or for example, with the student breaks and things, and people coming back from that, particularly in Quebec and Ontario, and plus also having large population centers, smaller provinces. So, for example, island province like PEI has a bit more control over access, people coming onto the island, etc. And their cases have largely been essentially been imported, etc. But then you can have like in Newfoundland, where early on there was at a funeral, somebody who was obviously infected, and then they had dozens and dozens and dozens of cases just out of that. Or if it gets into a nursing home or a long-term care facility, where you have a lot of vulnerable people, and it can very quickly, and then a high mortality. Yet some other areas where the more sparse population in the north, etc. Scattered out, and so there's just a whole range of issues. And then we have, for example, challenges in other collective living centers, shelters, etc. The challenges are for people who are homeless. And then in Indigenous communities, not that being Indigenous makes you more likely to catch the virus, but because there's can be a higher proportion of people with underlying chronic disease, overcrowded housing, those conditions that then make it more likely to spread in that situation, or to have serious consequences. So we find Indigenous communities across the country being, again, very careful about many of them limiting, visitors to the community, etc. Or in Ontario, and it's probably true in other provinces, where to retirement homes, there's no visitors other than essential, like caregivers, etc. Or if somebody is severely ill, or some other situation that's and that just adds to the challenge, because as often our world gets smaller, and suddenly it's really small. As the retirement home my mom's in is, they're served their meals in their room. They can't socialize. There's no activities, and can't visit, and so you just have phone or Skype, or whatever people do, and that's hard on people. And that's why, as things start to open up gradually and carefully, we need to be practical about it, But we also have to figure out a way to live with this virus, because it's going to be with us for a while. And so what are the things we can do to minimize the risk, minimize spread, and still be able to go about some kind of life?
Mm-hmm. Great, thank you. It's certainly on a lot of people's minds, the rolling out of restrictions, like you said, carefully and planned. There's a question here. I'm just going to read it word for word. You referenced public health as being local. How does that connect with current Ontario planning for an all-province approach to timing and nature of relaxation of restrictions when local experience in the province vary quite widely?
Yeah, it's always local because things happen locally, but they can happen in many places. And also, depending on, you will find variation within provinces. It's hard. You have to have some, basic guidelines or whatever, and then would adapt them locally, and particularly in institutions, etc. You need to be able to adapt that. The reality is that often at a provincial or national level, as much as we say we don't want a cookie cutter, it's hard not to have a cookie cutter in terms of, well, of course, this is the rule. And so, hopefully as things roll out, there's some flexibility to, for example, in a situation to add to that if need be. I'm not sure that most jurisdictions would be keen on, just because you don't have any cases in Muskoka, suddenly you can just do everything you want. That just, because you're going to have it quickly. It's kind of like closing the borders. The challenge is it's already there. Not that having controls and making sure people who arrive know what to do and isolate, whatever it is that's necessary at the time. But anybody who thinks that they can somehow just avoid this altogether is probably deceiving themselves.
Mm-hmm. Thank you. And another follow-up question, it worked out well, two different people, but what indicators would you look for that would suggest opening up is appropriate? Like, when's the time right?
Well, certainly, I think, there's still a lot of discussion about what that looks like, and it will vary a bit from jurisdiction to jurisdiction. But basically, it is about stable or declining numbers, a sense of where that is happening, and kind of situations where transmission is continuing, and you try. This is why they're doing it in an iterative way. In other words, you look and you say, okay, well, probably the most important and least risky, since we generally haven't seen that the surge that we were fearing, would be things like, maybe we can start to open up some of the elective surgery, like for cancer, or other things that are obviously highly anxiety provoking and necessary. And I'm supposed to get my other hip done at the end of June. Well, we'll see if that happens. It'll be nice, but we'll see. But anyways, and also other things. So, for example, Manitoba is opening up in the coming week. We'll be opening up patios. And so, you do that, and, make sure people understand, you still maintain distance, good sanitation, hand sanitizers, different things. Don't be in other people's face. Don't visit from table to table, different things that you can do, and see how that works. Mm-hmm. It'll be fine. But again, that's why the importance of continuing surveillance, identification of cases, contact tracing, treatment, isolation, etc. So important, and we may find we went one step too far, and then they have to back off a bit. But again, they don't want to have to do that, because again, it's it can be discouraging, and for businesses and things, on again, off again is really not a good thing. And at the same time, we don't want to be caught trying to start over again. And so it'll be, there's ongoing conversations, and people will be doing this slowly, and it'll be interesting to see. And we're also obviously watching what's happening across the world, right? When in different countries, approaches, et cetera, and putting it in the context of that country, well, what of that can we learn from that we can apply in Canada? And so, for example, it does appear that children not only don't get as ill, but they don't seem to spread it in the same way that adults do. And so, many situations where infected kids and none of their siblings or family get infected, whereas if it were an adult, they would have. And so there's just so much more to learn. And that's why, again, we need to continue to be cautious.
Mm-hmm. Thank you. You mentioned the, the backlog of services, and I'm wondering around public health services, and obviously everything, all the priorities have shifted, and how would you approach maintaining public health services? Because like you said, this virus is going to be around for a while.
Sorry, in what sense? Sorry, you mean like the regular public health, like immunizations and
exactly.
school, and depending on what jurisdiction you're in, etc. It is all hands on deck, but at the same time, one of the key things in any emergency or crisis is you need to also pay attention to the things. The regular things that if you don't pay attention to them will become a new crisis. It's kind of like, if everybody's, focused on X, well, you still need to, if you're on anticoagulants, you still need to get your levels checked, et cetera, and monitored. Otherwise, you could be in trouble. And as we're seeing in Canada, I just co-authored an op-ed. We'll see where it gets published, but with Heart and Stroke Canada, I had been on the board for a number of years. And but anyways, just about recognizing, and certainly hospital administrators and others will recognize that people are not going to emerge. In other words, we're seeing this around the world, people with strokes and heart attacks and other serious things that should be in hospital or going to a hospital are not in the same numbers, and encouraging people that hospitals actually are safe. And if you are having a serious health problem, you need to go to emerge and get cared for. And that this should not be a reason, because otherwise we're going to end up with people with either mortality or not getting the appropriate TPA or whatever after a stroke or other therapies in the immediate period, and we're getting proper rehab. All those things are it's really unfortunate to see that happening. So hopefully, and we're seeing more. I'm seeing in the media more reminders that if you are sick, make sure you go, and hospitals and others raising concerns about that across the country. And so there's all these things. You need to be able to have some people focused on those things that really do need to continue. Some things can be postponed. A few months of delay in your preschool booster, less critical. But other things maybe, and certainly they'll continue to deal with and respond to food outbreaks, and if there's water issues or any of those kinds of things. So, but it's true, and that's one of the things that I've been concerned about over the last 7 or 8 years, as many jurisdictions have reduced their public health expertise and capacity, and either cutting budgets or holding budgets steady or other things. And it's the thing is that all the things that public health does in between, in terms of preventing disease and injury, promoting health, understanding why some people are healthy or not, looking at social and health and other policies, et cetera, and working to keep, build resilience and capacity in communities, et cetera, and then as well as plan for and respond to the crises. And those are the same people that are trained, ready to actually engage in whatever's needed when you get into a crisis. And it is sometimes it is the first order of public good in health for governments is public health, and you need all parts of the system. You need a good primary care system, good institutional system, good public health, and it's the balance of those that actually allow us to both prevent as well as respond to what it is. And most of us would rather not need bypass surgery if we had the choice. But you need to have it there available for you when you need it. So,
That's right.
but the more we can prevent it, the more likely we are. It's kind of like sometimes I've talked about how if it weren't for polio vaccine, I wouldn't be getting a hip replacement because the orthopedic surgeons would be so busy with, everybody we could train would be dealing with post polio things. And so, so anyways, it's these things, it all matters. It's about the system and not just one sector.
Yeah. Lots of questions coming in. So I'm just going to jump right to the next one here. This is from Paul Gallant out in BC. Can you comment on how health leaders, managers, and not only those in public health, may further support efforts in their local jurisdictions? May further support efforts if their local jurisdiction is not yet highly infected.
Sorry, so how can they support efforts?
If they're not in crisis, how can they support the effort?
Oh, well, I mean, one is again, it's kind of like, and it's interesting how Alberta has started to haven't hit the surge that was feared, and have been sharing PPE and ventilators with other jurisdictions. And so it could be that, so for example, again, depending on your setting and the role, one is being prepared, first of all, obviously, should things arise, but also in supporting colleagues. And there may be, again, depending on the situation, there may be, much as hospitals in Ontario and some other jurisdictions are, when there's a nursing home outbreak, is sharing their staff to support support the response there. And so, there are different things that people have done. And actually, I'm quite pleased with the levels of creativity and innovation that has been going on, both in terms of, everything from in healthcare and in looking outside our own little responsibilities and supporting others, and even the innovations, like my next door neighbor, she's 7, and they play virtual hide and seek with iPads. Explain this to me, but it's they're figuring out ways to be connected without being together. And but also in adapting responses, etc., to be able to deal with stuff. And of course, if you're a hospital or facility and you have some surplus equipment momentarily, you need to be able to know you can get it back if you do have a problem. But those kinds of agreements can be reached, and if that's what's needed, and it seems that there's more and more supplies coming, and hopefully that improves. It is one of the issues for planning for the future in terms of what needs to be in provincial stockpiles, what do you need to keep on hand as an institution, what needs to be in the national stockpile, etc., so that we're better prepared, as well as having domestic capacity, much as prior to the influenza pandemic, we had a contract with a domestic vaccine manufacturer that we could produce enough vaccine for the whole country, as well as having stockpiles of antivirals that, because once you're into a crisis, it's you may have difficulty getting those things as people are experiencing.
Okay. How concerned should
anyway, sorry.
Yeah.
Actually, I'd be interested. You might some of your the colleagues around this, they may have some ideas that they'd like to share with their colleagues that maybe you guys could then send out to everybody too, because they'd be better at it than me.
We welcome the comments in the chats if anyone has any ideas. I know for me personally, my husband's an occupational therapist. We live rurally, and he's volunteered to work in long-term care homes, and so he's on a list ready to be deployed. So it's it is very warlike, and you do see creative things happening, and it's inspiring to see.
Yeah.
How concerned should we be with what's happening south of the border? We see the stats are still up there, and the growth that we're hearing about, and wonder what your thoughts are there.
Yeah, they were a bit slow, and there was a lot of mixed messaging, and they're starting to catch up now. But you look at a city like New York, some of the other cities, and what they've been facing, and they definitely hit the surge and the crisis in ICUs and hospitals, etc. And I don't know what the government's going to do, but I don't expect that the border will, other than for essential services and travel, I don't think it's going to be easing up anytime soon until it does ease off. A lot of I ironically spent a week in ICU in Florida at the beginning of February. Hypothermia, not related to COVID, but it might have been actually. Who knows? Yeah. And you just think of like so many Canadians. That's where they got it, was from our southern neighbors, and so it's. I think it's something that and we see even between provinces, where visitors and then isolating yourself for 2 weeks, etc. Make sure in case you have symptoms, but you have to be able to support those people at the same time, and until we actually have a vaccine, until we have effective treatments, really we're not left with much else. And so it's hard on people, right? I mean, people have winter homes in the States, they have family there, there's so many things. There's so much across the border, and that's just on hold for the moment. But hopefully things will ease off. But certainly they are challenged, and at least on my screen, I'm covering up the testing per population, etc. But it's if you can see it, it's. They still have a long ways to go, and then again, the politics is very different and very divisive, and then you have people doing, protesting any restrictions, etc. So it's not an easy thing, and until we have effective vaccine treatments, it's going to be. Anyways, it's really just magnified the polarity of that we've seen developing over the last couple of decades, and it just has magnified that. And I don't envy the challenges that they're facing.
No, I don't either. Similar vein, taking a holistic view of public health, and how can governments balance the risks of infection with the risk of economic damage?
It's a dance, and the reality is that that if you let things go wild, you're going to have economic damage, anyways, and a lot of deaths, and a lot of even though there weren't a large number of deaths, etc. I mean, basically public. During SARS-1, I mean, there was a huge crisis of competency in the health system and in governments generally, in the ability to manage these things. And so it's important to manage them as best we can. Governments at all levels have been trying to mitigate the economic impacts of that, and I think as we start to open up, I think that will be important. It's been a long time, and it's sadly there's a large. I mean, when you think of the millions of people that have become unemployed through this period, and then for a province like Alberta and a bit in Saskatchewan, and in terms of the impact of what's been happening with the oil, etc. On top of this, or and then even so like you think that terrible crazy thing in Nova Scotia, right, with the mass murder, and then COVID, meaning you can't grieve in the usual way or comfort each other in the usual way. So it just has so many impacts, and yet for good reason. But the sooner that we can find that balance of minimizing risk and still allowing life continue somewhat more normally is really, really important, but it has to be watched closely. And there is not, it's always a trade-off, and it's not like one trumps the other. You need to be thinking about both, and it's those conversations are going on constantly about, what that balance is. And they're not easy decisions for anybody. And I really feel for people who have, are unemployed, some in my family, and as well as the sense of isolation, the challenges for mental health, and the impacts on the economy, and people's businesses suffering or even losing their business and their dream. And will the mitigations ever be enough? Could it ever be enough? So anyways, let's just hope and pray that quickly we get beyond this.
Absolutely. Yeah.
Yeah, sorry, there's no one answer to that, right?
It's a complicated question. We're certainly all living the realities of both, right?
Well, it's like I can't see my physiotherapist like your husband's, there are people who, right? It's and all these businesses that are, and most people actually love their work, right? And they do it because they love it, and they make a difference. So
yeah, no, the impact, and you take away meaningful occupations, and there's that broader mental health impact. There have been a few questions about the second wave, and what leadership challenges would there be in having people go back? You move forward, there's a second wave, and you have to pull people back into social isolation or restrictions again. Can you speak to that?
Yeah, it's and why we're, obviously everybody wants to avoid having to go back, because it's harder the second time. Like once people, and people have generally been really good about this and doing what they need to do, and then finally you have a sense of relief, and then suddenly it's back. It's kind of like oh shoot, the cancer's reappeared. And so it's harder the second time, I think, and to the extent that there's any cynicism about this, it gets magnified. But you have to be, again, communications is key, being transparent, being open, why or why not, and why we need to do this at this time, and how it worked the previous time, etc. I mean, communication is going to be key, and that's going to be one of the biggest leadership challenges. But also coming to a decision, because it won't be an easy decision to reverse once you've moved down a path. But that's where it's actually been good that the messaging I've been hearing from premiers, medical officers, and others is that we're doing it in this way, and if we need to, we will, we're watching it closely, and we'll step back if we need to, etc. And it's important to pre-position that as a possibility, so people aren't surprised. I thought you said it was over, and so it's but no, it's a really hard, it's a difficult communications challenge. But again, that's where having set the stage, being transparent about the rationale and the reasoning, and also what we would anticipate, I think is all very, very important to that.
Mm-hmm. Question about during your presentation, and it says, thank you for an informative presentation. And one of the slides you mentioned that there's a lack of education regarding the Ebola virus in Africa. There's a curiosity around, was it a lack of education as in few public health experts, or an inadequate education of the public?
Oh, no, it wasn't. It was just that basically education levels were low, literacy levels were low. And so communicating, and also education in terms of, understanding infection, spread of infection, what makes us healthy, all those kinds of things, because the, education levels generally are low. And so again, the communications is more difficult. And again, with its history of civil war, etc. But the point being is that the education infrastructure, health infrastructure, primary care particularly, was very poor. So you don't have a foundation to build on. It was less about, and certainly they don't have health professionals or public health professionals to the same degree that you would anticipate and expect or need to do that, and having an ongoing relationship with communities, etc., around public health measures or whatever, and so it's a very fundamental capacity issue, not just in health but also in education.
Right.
And so it was, yeah. So.
Yeah. Now I'm reading the questions and trying to combine them, because there's a theme and a few questions around, and we spoke about this briefly before the presentation started, is that, the herd approach and letting people go out and infecting each other and that kind of thing, and maybe sharing your thoughts on that.
I'm not a fan of herd immunity other than through immunization, because the problem is well, it's true. I mean, eventually you'd get over it because everybody who's been infected who's potentially infected. However, and the point of herd immunity is that if you're immune, you're not going to catch it and you're not going to pass it on. And so you have all these breaks in the population. So, even if person X is infected, they don't come in contact with somebody else who's at risk, who then can become infected because enough people don't pass it on. So you reduce that. That's the theory. But the problem is, it's kind of like, when I was a kid in the 50s, chickenpox parties, right? And, it's much better to get it when you're a kid than when you're an adult. Problem is, you can't predict which of those kids is going to end up with encephalitis and brain damage, or other complications, etc. And in this case, do you really want to encourage filling up the hospitals and ICUs and overwhelming by having all these people that are sick? Some, it's true that the majority won't have serious illness, but enough will. And do you really want to encourage that? It's interesting too. I mean, when you look back at 1918, and the East Coast had the highest mortality rate. And that was because there wasn't any social distancing. The theaters were all open. They'd still have their parades or whatever. But as the pandemic progressed, and as it moved west, right, as it migrated west, mortality rate was less because they started doing measures of social distancing and hand washing and other things, and so that actually reduced the mortality and the rates in those as it moved west across the country in North America, and they didn't have ICUs or ventilators or antivirals or anything like that. And so that to me really speaks to the when you don't have a lot, or even if you do, the value of these measures in reducing spread, and as a result, reducing mortality, or reducing, if you have exposure, maybe it makes a difference with the level of exposure that you have in terms of your risk of serious disease. And still a lot of things we don't know, but the principles are the same, and it proved itself there, and so far has proved itself in what we're facing now.
Terrific, thank you. I'm looking at the clock and aware that we're quickly running out of time. There are unfortunately some questions left, but I will wrap it up there. I just want to mention briefly, next week the college is offering, we have regular group coaching sessions for members of the Canadian College of Health Leaders. Next Wednesday's group coaching session is targeted towards those working in long-term care. And right before that, next Wednesday, we have a fireside chat with a CEO from a long-term care facility out in British Columbia. Her name is Karen Bailey, so please join us for that. I'd like to thank the audience for joining us, for your time and your engagement in lifelong learning. Your pursuit of knowledge will contribute undoubtedly to the sustainability and improvement in our health system. So thank you everyone for participating today. And of course, thank you, Dr. Jones, for your time, your generous sharing of your knowledge and experiences. I'm grateful to have been able to hear you speak. So thank you.
Oh, it's my pleasure. And I hope people enjoy this special edition when it comes out. We've got a lovely mix of authors, you know, with both Canadian and international perspectives on not just, you know, pandemics of influenza, et cetera, but other things of import, et cetera, and a lot of lessons in there that I think people will find interesting reading, and I hope you do. And thank you very much for this. It's been my pleasure. And if you want, if some of those other questions, Brenda, if you want to send them to me, I can respond by email, and you know, such as it is. Anyways, as I often say, there's no dumb questions, but there may be dumb answers. So.
No, we'll keep those if we can. I'm looking at Jenny and Amy here, hoping that they'll work their magic and keep the questions, because I don't know how to do that. But thank you for that offer. We will take you up on that. And we'll just wish everybody a good afternoon or morning or day, wherever you are, and stay safe, everyone.
Stay healthy. Yeah, for sure. All the best.
Bye.
Bye.